What up? We are rocking and rolling. Dr. Jared Ament, welcome in to the studio at long last. My doctor, my neurosurgeon.
Good to be here.
I just want to say thank you so much publicly on record. You've changed my life. It's only a month since my surgery, but I feel like I've gotten my life back in many ways. It's been revolutionary.
My honor, pleasure. And you know what I'm going to say?
What are you going to say?
I told you so.
Yeah. Maybe share what you mean by that for the audience, because I was terrified going into it. You had to basically, you were like, I'm going to drag you in screaming and crying, but you are going to greatly benefit from this. And yeah, I was I mean, I remember like wheeling me into the operating room. I was like, even in that moment, I felt like pulling all the freaking things out of my arm and getting up and running out.
You did. I remember. It's one of those things where when we developed a kind of a friendship and relationship around this, 'cause it's been going on for a while. And I always struggle when we're talking about, as a neurosurgeon, I deal with death, dying, and disability on a daily basis. And we had this conversation. I mean, I struggle around this aspect of the business, this aspect of delivering healthcare, because it isn't life and death. It's quality of life. It's a little bit more boutique. Right? And this boutiquiness is kind of a gray area. It's a gray zone for people. Like, I don't feel comfortable as a neurosurgeon pushing someone. And yet, in your case, and people like you, I truly believe in the technology. I truly believe in the surgery and believe your quality of life would benefit. At some point, like I said to you, you're kicking the can down the road for another day for what? To pick up the same can? Hoping there's some miracle? And there may be 10 years, 20, 30 years from now. But currently, looking at the data, and you know more than anyone, no data is perfect. There's nothing out there that's perfect without bias. Doesn't matter how randomized, control trial, whatever, right? FDA, there's always problems with trials, and that's just the nature of design. But with the data that we do have, with the experience that we have, for someone like you, this was the best option for regaining high quality of life, high functioning quality of life. So I struggle with it. And I told you so, it was a joke you and I had, but there's no crystal ball. Not everyone does perfectly. There is no 100% in surgery, especially neurosurgery. But you were as close as it gets, right? I mean, we looked at your anatomy. We'll talk about that. I know you wanted me to talk about it. We'll look at the options. This is what the device, this is what artificial disc replacement was designed for, your specific case. And that's why I was pretty confident. I never gave you 100%.
No.
But I felt really good that I could do something for you positive.
And why did you say it's a boutique procedure? Because it's elective at the end of the day?
Yeah. I mean, like it's not a brain tumor. When I have a conversation with a patient about a brain tumor, could be life or death. This is really no discussion. We have to do this surgery. This is a choice. You could continue doing all of the conservative care options that you were doing this is not new for you. You've been struggling with this for a while and you've been dealing with it in the best way possible. And I commend you for that. But at some point, the efficacy, the effectiveness of these interventions wane, and you're dealing with a mechanical issue that needs a mechanical fix. It's boutiquey because you could have continued on with lifestyle modifications, with pain medications, which I despise, but you despise. You could continue on with injections and exosomes and stem cells and all of the acupuncture. A lot of these things I truly believe in. But at some point, if they're not working and you're having to adapt your lifestyle, your quality of life at your age, your level of activity, too much, this is kind of what it's for. But it's boutiquey because you're not dying from it. And I'm putting you into an operating room under a stress-inducing, not just emotional stress, physical stress environment with some risk, right? It's not zero, right? We're going through the front for an artificial disc, so you're moving around vessels and stuff. There's not zero risk here. You could live with it. God forbid there was a complication, you would have said, oh my God, I should have just lived with it. Right? That's the boutique is, and it's boutique because we're doing this now as an outpatient. People, it's crazy, but it's routine. We, especially at your level at L5S1, people go home the same day, safely. So it's not like you're coming into the hospital for a major operation. You're in the hospital for 3 days, 4 days, 5 days. You're going to rehab. You may be in the ICU. Those are serious operations. This used to be considered a serious operation. This is very elective, very boutique, under controlled settings with experienced hands and that's not just me. I'm not patting myself on the back. It's a team. It's very much a team effort. It can be done safely and effectively.
I mean, it's true. It's like a miracle. I mean, like, it's not a miracle. I'm sitting across from the person who you know, went to school for, you know, a dozen or so years, if not more, and, you know, and performed this very skilled, highly technical procedure. But it's just remarkable that, like, the degree of mobility that I had right after the procedure. I mean, I got myself into my brother's car. We drove home. I mean, my stomach was achy where they performed the incision, but like my back felt totally fine. Like I had zero back pain. And now we're as we record this, we're 1 month out, and I'm not even exaggerating. I'm not blowing smoke. I feel 100%. And my back, like it's unwound 10 years of back pain. Like I feel like I have the back that I had when I was 18. It's crazy.
I'm happy for you. And you did your research. I mean, you spoke to some of my patients. You asked, you know, can I speak to some of your patients that are very active or had, and obviously these are success cases, but we talked about, you know, the 1 in 1,000 that has persistent pain or it wasn't perfect. And the other, you know, outlier who's an ultra marathon runner and really using a disc like this that's never even been tested, right? So I'm happy for you, and I hope it lasts too. I mean, the data suggests that this should be you for the next 20, 30 years, right? Your quick recovery, I think, is in part because you are healthy. You're a good candidate, but that's why I was so confident. You are a great candidate for this technology. And in many ways, it is miraculous. You have a new functioning disc where if we look at your old imaging, we look at and compare how you're feeling, it doesn't surprise me. I still approach you and anybody like you cautiously. It's still surgery.
Yeah, of course.
But I always say, you know, people always ask me, oh, it's like surgery is becoming this, you know, this out of network cash business. I always approach these things very carefully because no matter what I do, it's not about the insurance and the this and who's paying, what's paying. For me, it's about doing the right thing, right? If you do right by people, everything else comes. And so I always want to make sure we do right by people. I wouldn't put my name, my training, my research. We're doing active research in this space. I wouldn't invest all of that time and energy into it if I didn't believe it. Right? And I believe in the technology. Can we get better technology? Can we make better discs? 10 or 20? Probably. Is there a time where I could see stem cell injections that magically regrow a disc? Sure. We're not anywhere close. But there's always room for improvement, right? You can always make the Ferrari that much better the following year, right? So, but with what we have, I truly believe in this technology for someone like you. And that kind of segues into patient selection. Why was I so confident? You were a great candidate. Not everyone is. And it's really important people listen to this or go on Google or wherever they're searching. It doesn't mean that it's for everyone. And that's really important.
So what about me convinced you that I was an ideal candidate?
So 2 things. One is the pictures. And I always say to my patients, treat the patient, not the picture. But when you can treat both, when the picture kind of corroborates what the patient is feeling, the patient's symptoms, it's a higher chance of surgical success. So it was your anatomy on the pictures and then your symptoms, how you presented. I mean, you even came back once before surgery asking me to re-examine you, right? To do another, just to make sure it wasn't something else. But it's a very fair point because one of the hardest things we do in surgery is, yes, we have a picture, but can we be sure, 100% sure that it's what's causing the symptoms? Sometimes it's as clear as day. Sometimes it's not. And in any element of uncertainty in the diagnosis and the process then creates uncertainty into the surgical success.
Yeah, I mean, I did a ton of due diligence. I think I had maybe 5 or 6 opinions from, I mean, you...
Overstatement, but yeah.
Yeah.
No, or understatement, actually. I mean, you definitely did your due diligence, which is great.
Yeah. I was in there's like a Facebook, group for artificial disc replacement support. And you also, I mean, and this is awesome. This is another reason why you were the perfect fit for me is I asked you to, and you complied. You connected me with some of your patients. So I got to speak on the phone with patients who had undergone similar surgeries, which I think was an amazing thing that I was able to do thanks to you. And that allayed a lot of my concerns. And yeah, just knowing that you weren't treating just based on like the image, based on like a biomarker or something like, here, take a few drugs, this is like you examined me and we ruled out all the other stuff, and you presented the risks. And I just thought it was Yeah, at a certain point, it made perfect sense. But there was something that you actually said that I found really valuable. We were texting, and you were like, at a certain point, you have to trust the process. You have to trust the surgeon. You know, you can go and get 100 different opinions, but at a certain point, there's diminishing returns.
Absolutely. Yeah. I mean, there's a joke, right? That you ask 5 spine surgeons how to treat one problem, you get 6 answers. There is there's an opportunity cost, and there's a diminishing return at some point. Multiple opinions, multiple sources of information, and you're just like, I don't even know where to begin anymore. I mean, you just have to start over. Trusting the process, trusting the surgeon becomes harder and harder, and unfortunately in the world we live in today, right? There are all kinds of people incentivized for all kinds of reasons. There's economic gains. There's the pharmaceutical industry. You talk about this on your podcast. There people have incentive that is not always in your best interest. I think it's very important. I still believe in good people and there are people doing right. And at some point, you have to trust the process. 3, 4, 5 opinions may not make sense anymore. Find people you trust. Do your due diligence. Do your research. Speak to patients. Sometimes those chat groups are good. Sometimes they're not.
Yeah.
But if you're a discerning mind and you can use those sources for good and pick out what's right and what's wrong, then that's great. Sometimes you can be flooded with so much information, it really kind of confounds the picture and you don't know what to think.
Well, there's like a selection bias.
Sure.
I realized at a certain point that, because I had come across all of these like horror stories about these discs, and I sent a handful of them to you, but you have to remember at the end of the day, people who are scorned by whatever it is, be it the restaurant that they just dined at or this somewhat novel medical procedure, like those are going to be the ones that are going to be most motivated to leave the negative review or the post within that group. Those that for whom the procedure has worked out perfectly, like they're out living their lives.
Right.
They're not sitting in these message boards. So yeah, I think it's at the end of the day, I'm just so glad that I went through with it.
I'm happy for you. And as we were kind of joking a little bit online with some of our workout challenges, you're a month out. Now is going to be quite telling, because at this stage in your healing and your recovery, unlike a fusion, and I'm sure you're going to want me to talk a little bit about the differences for the viewers, but for you in particular, we joke online, but this is where we start. At this point in your recovery, we're going to start actually letting you do more and more and more, to the point where you get to use this disc, use your back, and actually see the benefits. But also remember, for the last several years, you've been babying it. You've been relatively limited in some of the things you're still an active guy, but you've been more limited. There's some deconditioning that's happened around that. And so a lot of those core muscles and a lot of the back and abdominal muscles that have kind of compensated, some others have dwindled. And there is a little bit of atrophy there. And so you're going to start to rebuild those and be able to, because we've taken away some of those pain generators.
Why do you think, though, that this narrative exists that back surgery, like obviously I wouldn't wish back surgery on anybody, right?
Yeah.
But there is nonetheless this narrative that, I forget the exact statistic, nor do I even know where it comes from, but I've heard that like 50% of back surgeries leave you worse off than you were before.
So it unfortunately comes from the historical fusion data, right? The idea is that surgery begets surgery, begets surgery, begets surgery. When you fuse the spine, and we have models, the idea of fusion is this okay?
So if you're just listening, listening, Dr. Ament brought in like all these models. This is super cool.
So this is just a spine model showing, screws and rods with a little titanium spacer that goes between the disc. And this is the front part of the spine. The spinal column is in the middle, and this is the back of the spine here. The concept of a fusion, it's over 5 decades old, isn't awful. The idea is that if you have friction, grinding, degenerative disease, not unlike what you had, one of the ways to take care of the pain generator is to remove motion, because motion in the setting of degeneration motion doesn't cause pain. We are born with motion. We have motion. But motion in the setting of degenerative processes or injury causes pain. So get rid of that. So that works, sort of. It works, you feel better. The problem is that the spine is designed to move. right? Everyone knows this, right? They're moving, bending. The spine is designed to move. But if you think about this, think about it a little bit like a shock absorber on a car. If you are driving a car and you have one shock absorber that goes bad and it's blown, you could still drive the car on 3 out of the 4, right? It's just not comfortable. But if you lack the symmetry and suddenly one shock is not working, what happens to the other 3? They'll wear faster, right? They're going to take the grunt of the fact that one's not holding its own. The same thing happens in the spine. Even if I get rid of a little bit of motion at the segment, sure, with the fusion, but that's just one of the negative effects. The sequelae here that's really important is that if the remainder of the spine is compensating for this segment that you have now immobilized to treat the problem, you will have increased wear and tear over time. So this answers your question in a little bit of a long-winded way. Sorry, I tend to be verbose. Surgeons like to, explain. But the idea is wear and tear over time, surgery begets surgery begets surgery. It doesn't necessarily mean that this surgery that you did in the fusion on failed. It just simply means that you may need more surgery at other levels. It's called adjacent segment disease, okay, ASD. And so that's one of the reasons why back surgery got a bad rap, and it makes sense. So what we've been trying to do, at NSG, at my group, my partner, Dr. Vokshar, is really focus on the research, get involved in research, do our own clinical studies, and look at ways to even take what's already present, what's existed, and make it better. Motion preservation makes sense. Again, another very simple analogy. Hips, knees. I'm not an orthopedic surgeon. I don't know anything about hip or knee surgery other than it makes sense. People seem to do well, right? Has anybody that you know of in the last 20 years got a hip or knee replacement where they can't move the joint?
No.
Right? Have they ever locked it in place? Now they did. Several decades ago, that was the only cure. You get it fixated. But today, that sounds like heresy. It's crazy, right? Who would lock their hip or knee if you don't have to? Get a knee replacement, get a hip replacement. So for us, the concept is the same in the spine. Why are we locking segments of the spine together when there are better alternatives? People got away with it because there's so many segments of the spine, the other segments compensated. But what we're learning is that compensation can be detrimental as time goes on, especially we're younger, we're healthier, we're harder on our bodies. So we start seeing these degenerative processes earlier.
And another thing that you said is that, if you are a candidate for ADR, and I would love for you to speak to, who is or isn't a candidate for ADR. It's my understanding that some people have no choice but to fuse, even today. Yeah. But you can with a fusion, there's no changing that once it's done. With an ADR, if the ADR doesn't work out, you could ultimately still one day fuse. So at least you have optionality.
Sure. And that another reason why we believe that this is the most ethical approach to spine surgery, because we have backups, right? Once you're fused, you're fused. Now, there's some experimental work looking at kind of revision fusions. Can you convert it to motion? That is highly experimental, right? And it's nowhere near where it should be yet. But in general, if you're fused, you're fused. And so I love the idea of saying, if it's safe, if it's appropriate, let's always err on the side of motion preservation first. And if it does fail, there are some, definitely in the neck and the cervical spine, easier than the lumbar spine, that would even suggest replacing a motion preservation segment if it fails with motion, to do an ADR revision. More controversial, it's harder, there's risk. But a safe backup, if for whatever reason we go through the front and the lumbar spine and we have to do an artificial disc, for whatever reason it fails, and the failure rates are low. But if it ever fails, we can actually keep it as a spacer and just leave it alone and fuse from behind. So we do have backups. The people that need fusions are almost always patients who have really frank instability. This is often, you see this in trauma. Patients, bad car accidents, the spine is literally severed, right? This level of instability, an artificial disc can't help with. It can't stabilize the spine so it's safe to try and get someone walking again, right? Your artificial disc is functioning kind of in a milieu of stability. It's, you have your spine, nothing's happened to your spine. I'm literally replacing a diseased disc and putting a new one in. So the rest of your spine is functioning as it should. In major trauma, that's not the case. So there's ligament, bony disruption to such a degree. Those are patients that need fusion for safety and spinal cord health and the ability to hopefully walk and function. Other patients where it's a little bit more borderline is, as you get older, whether or not bony architecture changes, like in osteoporosis as people age, if the bones are strong enough to accept the implant. And that's an area of active research. My old mentor and I have looked at kind of injecting cement into the bones, which we do for fractures as a standard of care, but using that to help with the architecture, that's still kind of up for debate.
And what about, I heard that if you have like arthritis of your facet joints, that might not necessarily.
So this is a great question.
well.
Yeah. So for the viewers that are watching, all right. Disc is in the front of the spine, anterior closest to your belly, spinal column in the middle. This is the thecosacral, all the nerves. Usually below the level of L1, L2, there isn't a spinal cord. It's called the cauda equina. The cord ends higher than people think, and it's just a kind of a tangle of nerves going down. Cauda equina is like a horse's tail, right? And so it looks like the tail of a horse. And so there really isn't a cord here. It's really just nerves when you go down to the lower lumbar spine. But in the front is your disc. This is what we replaced in you. In the back are the facet joints, which are, like other joints in the body, also related to movement, motion. So the idea has always been one of the original, remember, artificial disc is not new. It's been doing it in Europe for over 30 years. In the United States, we have 20 years of data and over 1,000 peer-reviewed publications just on the lumbar spine itself. Cervical is even more. So, the original FDA data, the trials where all of this was based on and how the clearances came about, suggested that if you have an artificial disc replacement, that if the facets in the back had too much arthritis, bone spurs, growth, rigidity, that it was considered a contraindication because you'd have motion preservation in the front and you'd have potentially stiffness or pain or a generator in the back, and the two would be contradictory. They'd be fighting each other. And so the assumption was that the failure rates would be high, or if the facets were incompetent, that the artificial disc has never been tested in the setting of no facets, and therefore you shouldn't do it. That's a potential for instability. Now it's unclear, and certainly people with mild or moderate facet disease, especially if they're younger, healthier, active, I would still say they're a good candidate because some of the data suggests that when you have really bad disc disease, the facet pain or the facet arthritic changes is actually due to the disc disease. It's compensating for the lack of a disc, lack of your shock absorber, right? I don't know cars as well as I know spines, but I assume if the shock's going, then maybe the strut starts to go. I don't know, right? The strut will go next. There's the same kind of concept. Something's going to go next, and that's at the same segment, let alone the adjacent segment. So one of the theories is that if you put in an artificial disc in the right patient who has mild to moderate facet disease, you can actually offload the facets. You can take the wear off those facets and actually help the facets heal a little bit, help the facet pain, the facetogenic pain resolve a little bit. And that's something that we're kind of pushing the envelope with. It becomes more complicated when you really have severe non-functional facets, because then you're asking the disc to do probably too much, and the facet joint is really separate from the disc in that case. And that's part of our trial that we've started, and as far as I know, we're the only in the world, but we're certainly the only in the United States that are doing, and you never needed this, thankfully, but we're doing this 360-degree arthroplasty replacement, where we're doing an artificial disc in the front and an artificial facet, the TOPS device, in the back. And that's potentially, could be a paradigm shift for the motion preservation space. It's very early on. The 18, 19 patients that we've done, and I believe we're the only site now that has done it, especially under the auspices of a formal trial, have all done really well. But it's very early data, very early on. So we're looking at biomechanics studies. We're looking at collaborations with the industry. Both companies are trying to help us see if it makes sense. We're looking at academic collaboration with the University of Maryland to do further studies to see if this can be an option for patients who would not be a candidate normally for an artificial disc because of their facet disease.
Such amazing, important work you're doing. Damn, so cool.
Thank you. Trying.
I remember reading the radiologist report for one of my more recent MRIs, and I had mild facet hypertrophy, which I am assuming was due to the stress being imposed by the severely degenerated disc that I had. And as an N of 1 experiment right here sitting across from you, I mean, you didn't touch the facets, you replaced my disc with the artificial disc, and that's resolved all of my pain. which I'm assuming. So my assumption there is that the facet stress, the facet hypertrophy was due to the stress being imposed by that.
And this is kind of what
disc.
I was referring to. That's the theory. That's what we're hoping. We're offloading the problem. I mean, the term spondylosis is used a lot. People see it in the literature, and what does it mean? It is this general term. Is it degenerative disc disease? Is it facet disease? What exactly is it? Spondylosis is an idea that the spine degenerates and compensates, right? And it works together. And so I agree with you. I think the fact that your disc was so bad and progressing, because we followed you for a little bit, that your facets were under undue stress, unnatural stress compared to the rest of your spine. Because the rest of your spine looks really quite good. The only thing you lost was a little bit of your posture. And I think a lot of that was due to aches, muscle spasms, the fact that the disc was so bad. And people, it's a little bit misleading, but people who lie down in an MRI machine have a really hard time lying down flat when they have pain and they have a disc problem.
Yeah.
So you see straightening that sometimes is artificial, but sometimes is real, which is why we get x-rays and bending x-rays before surgery like we did with you.
I mean, it's crazy. I noticed 10 years ago when I first had my injury, I noticed that there was like a straighten. I didn't have the language to describe it. But I knew that there was some change to the curvature of my back.
Yeah. And one of the first things you said to me, even when you were sore after surgery, was that you felt your posture was better.
Yeah. Well, to my profile now, I look in the mirror and I have like a curve to my low back.
The small of the back people talk about, that's lumbar lordosis. And that's a natural curvature that we do lose as we get older. But it's interesting, in not the artificial disc space, but in the people who do screws and rods, scoliosis, complex, long constructs, there's a direct correlation between lumbar lordosis, posture, and quality of life.
Well, back pain today is super common. It's one of the leading causes of disability worldwide. Apparently, 80% of adults experience back pain at some point in their lives. So who listening to this, is there like a checklist? Like how might they know whether or not they are candidates? Obviously, seeing an expert such as yourself is great. But as a first step, like how might one know if they're a candidate for ADR?
Yeah, and unfortunately not everyone is a candidate, and then just have to kind of set expectations. But, back pain is where it starts. Sometimes there can be referred pain down to the glutes, the buttocks area, the hips, legs. You can have radiculopathy. People refer to it as sciatica. Not all pain shooting down your leg is the sciatic nerve. There are other nerves, but certainly that type of referred pain, numbness, tingling, there is always an element of back pain. If someone were to come to the office and say, I just have shooting pain down my leg, usually that refers to a disc herniation. Whereas the bulge, you can have a healthy looking disc, but some part of it has bulged, has ruptured into a nerve. Those patients aren't necessarily candidates. Those patients can get an injection. Those patients could get a microdiscectomy, a little microscopic procedure from behind just to shave that bulge away so the nerve is free. There's always an element of what we call axial back pain, which is a loading, right? If you're in the gym and you're lifting weights and pressure on your torso causes more pain. If traction helps, right? Those are certain things that we look for. It becomes a little bit trickier if it's positional pain, lying down versus standing. People who also have worsening, we call it neurogenic claudication. So the ability to walk, if your legs get tighter, sometimes those people have stenosis, tightness in the spinal canal, and they're not necessarily a candidate. So there are checklists. We're looking for things that you have and don't have. And then we compare your symptoms and how you present to imaging. But interestingly enough, which is why I believe so much in conservative therapy, we also really do address and take into consideration how you respond to those conservative therapies. So how you respond to an injection, how you respond to traction therapy, how you respond to PRP or stem cells or acupuncture. That actually plays a role when we look at your anatomy and look at you and examine you.
Yeah.
I'll look. So you asked this question also before because you came to the office a second or third or fourth time, because you wanted me to look at your SI joint and do certain provocative tests, right? So this is actually very common. The lumbar spine gets often confused with SI joint or hip. So orthopedic surgeons will send to us and we'll send back and forth trying to figure out, is it the lower back or the hip or the SI joint? Same thing in the neck. is it a cervical spine issue or is it a shoulder issue? Very common. Usually if you have a neck problem that radiates all the way into the hand and the fingers, that's not a shoulder. That's coming from the spine.
Yeah.
But when it stops at the shoulder, that could be shoulder or neck. So this is a very common problem. So a lot of patients, I'll get calls from people saying, I really, I listen to Max Lugavere. I need a disc replacement. I said, okay, I'd love to, I'm happy to help. Let me see you. And it's a hip issue. It has nothing to do with the spine. Again, as long as everyone's doing their due diligence, open to a thoughtful diagnostic process, no one should rush into it unless you can't walk and we're having some neurologic problems. That's different. That now suddenly it's not an elective procedure anymore. Not walking, you need to be talking with someone. And that's not due to pain. I'm talking about a physical inability to walk due to strength or some loss of sensation. That's a completely different issue. But if it's a pain issue, radiating or not, you need to, be evaluated and understand that it may be your lumbar spine. It may not be, because there are things that are referred to one another.
But axial pain during axial load?
Axial pain is a big one.
Yeah, I had that.
You did. And I can, in your image, which we can look at, but I mean, it really, really certainly could explain it. I mean, you have something called modic changes. Again, don't treat the picture, treat the patient. But the picture helps. It's not a window into the soul, but it's a window into something, right? It gives us, so it helps in MRIs. You find stuff. Just imaging is dangerous because you can MRI your whole body. You're going to find all kinds of things. Doesn't mean that you have to do something with that information.
Well, yeah, there's also this lore that I've heard just over the course of my 10-year journey with pain that you can perform an MRI on 10 people and half of them will have disc changes that might seem to be causing pain, and those people are walking around without pain.
Absolutely. So again, treat the patient, not the picture. At the end of the day, I'm only actually going to get a picture if it will give me some helpful information to guide a patient, surgical or non-surgical. And so a patient needs to have symptoms. If people are doing, prophylactic imaging, Pernuvo tests, or that's a plug for Ament. That's the only one that I know, but there's a whole body scans out there. It sometimes doesn't mean you have to act. So you don't need to make an appointment with a neurosurgeon just because, some full body scan says you have disc changes. Your body is your guide. Now, that's actually really quite important. Pain is our body's natural way of telling us there's a problem. So I ask patients, you don't necessarily need surgery, but don't ignore your body. Because God forbid, and I've unfortunately had this. Now, you weren't really at risk of that, but there are some patients who have come to me, had pain, were so apprehensive about surgery that they just said, you know what, doc, thanks. I trust you, but I'm young, I'm healthy. I'll deal with it. I'm going to go to the gym. I'm going to get all the conservative therapy. I'm like, okay. And pain then evolves into numbness, tingling. And then before you know it, it's weakness, loss of bowel or bladder function. Suddenly they're falling, can't walk, their foot stops working. You've now ignored your body's signals of pain, and we now have a neurologic injury that sometimes I can't and no one can fix, at least fully. At that point, if someone comes to me, the promises and crystal balls and all expectations are kind of off the table. At that point, I say, listen, surgery is now urgent, and there is no holistic or conservative care that can help. And the goal of surgery is to prevent things from getting worse without a guarantee of getting better. And your neurologic recovery is really dependent on your body. As a neurosurgeon, I feel like I'm a steward of the nervous system. My job is to be of service to patients who are in pain or at risk of neurologic injury or dysfunction. Sometimes I end up getting to people, or they get to me, too late. That doesn't mean everyone needs surgery, and I certainly don't believe in prophylactic surgery. Right? I'm not going to do something if you don't have symptoms unless there's an impending disaster. Right? There have been a patient, especially in the cervical and the spine, where the cord is so sensitive, that have severe stenosis. There is actually literature, there is data in that particular case, in the cervical spine, where a decompression, making sure the spine is safe, is ethical even without symptoms. Because if you ignore it, that type of finding, the consequences can be disastrous.
So you don't want to rush into surgery, but there are also compelling reasons to do it sooner as opposed to later.
Right.
And maybe you can talk about my anatomy, because at a certain point, correct me if I'm wrong, but at a certain point you cease to be eligible for ADR and fusion becomes the only option. But even probably prior to that, you're still causing adjacent level stress, like on the adjacent discs. And then there are bone spurs that start to grow. And so, you want to be able to, you want to nip it in the bud sooner as opposed to later so that you don't require ultimately, a more complex procedure.
Sure. Which is kind of, it goes back to what our, how we started the conversation about boutique, versus elective. So I think in your case, I don't know if the viewers can see this, but we're looking at his MRI. And this is basically a sagittal view, which is a view from the side. So this here is kind of the belly, the abdomen area. And this is the back. This is his skin. And this is an axial view, which is kind of a cross-sectional view. And you can see the green line kind of going down through the spine. And this shows me where I am in space as if he's lying down on the MRI machine. So this becomes the front. This is the belly. And here is the back, the skin, and the musculature, the vertebral body, which is the spine, the vertebral body, the bone in the front. And then in the back, these are the facet joints we'll talk about. But the part that's particularly concerning for a neurosurgeon is this white rounded structure here. That's the thecal sac. That's the kind of the continuation of the spinal cord where the nerves, these little dots, those are slices, it's a cross section, are kind of floating through the spinal fluid like oil in a car, nice and lubricated, then going down into your legs. And
those black dots are nerves?
These black dots are nerves.
So cool.
And so in your case, you don't even need to be a radiologist to see that something is definitely different here than the rest of the levels, right? And this is L5 and S1, where the lumbar spine kind of articulates with the sacrum, and the sacrum then goes on to articulate with your hips. Now, the part that concerned me the most with you was not only the fact that your symptoms, were unabating despite many, many rounds of conservative care, that we noticed some further degenerative changes at this L5-S1 disc. Thankfully, you really didn't have a significant disc bulge into the canal, which is why you really didn't have significant sciatic type pain. But what we also started to notice in follow-up was subtle, and again, I don't believe in prophylactic surgery, so I didn't address it in you, but I did indirectly, is subtle morphologic changes, kind of appearance and shape of the L4-5 disc compared to the other discs above. That made me nervous because in you, basically what it told me was that your L5-S1 disc was no longer a functioning shock absorber. Your car and your 3 remaining shocks, obviously you have more in the spine, was already was already appreciating that adjacent segment stress. And so you had symptoms, you had evidence of changes already above the level in question. And then you had something which kept showing up in you, was these kind of, you see this white flare in the bone? So that white flare is called modic changes. There are 3 types of modic changes. This is modic 1. It's a imaging characteristic. So modic 1 versus modic 2. Modic 2 is actually from ischemia, where the red bone marrow is replaced with yellow fatty bone marrow from ischemia, from lack of oxygen. Modic 1 is different. Modic 1 is edema. And why do you have edema? Because you have friction. Your bone is literally hitting each other, grinding, because you don't have a healthy shock absorber disc. So in your case, this was kind of a slam dunk. It made sense that we had to do something. Now, a fusion, we have this guy, if we were say just to compare apples and apples by going through the front, this is called an ALIF, anterior lumbar interbody fusion versus the disc, right, which is also anterior. But this would have certainly helped you at L5-S1. It would have increased your height. He's a little bit taller, everybody, in case everyone is wondering. He is.
By how much? About like a half an inch?
Yeah, maybe a third of an inch.
Third of an inch.
If you over, that's a technical nuance, because if I over distract, if I actually made you too tall, you'd be in more pain right now, because what I try to do is replace your height normal. Everyone always thinks bigger is better. It is not. In spine surgery, we know that you can have an over distraction injury. You can really pull on those nerves. Remember,
explain what that means for lay people. Distraction, because that's like a confusing term.
Yeah. So remember, this collapse that we're pointing to here in you has happened over years, many years. In the time it takes me to replace this and open you up and make you a little bit taller, is about an hour. So I'm correcting your anatomy in an hour. You have been degenerating for years. That is a shock to the system, because your body has adapted to the degeneration. Your body, as our discs, as our shock absorbers wear, we get shorter, right? And so when I replace that and I make you a little bit taller, that action of making you taller distracts. It's like going under traction if you're hanging, right? If you're hanging by your feet, it's pulling you apart. When you pull you apart, it's great for the disc, but the muscles are pulled, the nerves are pulled, everything is pulled. That pulling apart is called distraction. Now, usually you have to distract a lot to get true injury, but even a little bit of over distraction can cause a temporary transient injury that is really debilitating for patients. And so I always tell people, when you lie down, you actually distract more. You actually pull apart. So the best thing to do after these surgeries is to sit up or stand up, because you weight bear, you axial load, helps things settle. And so we never, and this is a big mistake early on when people start doing these types of surgeries, because you don't talk about it in training, is not to overstuff, not to put in things that are too large. I really try to replace your anatomy with what you have, and as close to a match as possible. And that's important. And so, yeah, I mean, in you, replacing that disc and trying to restore that normal segment, that normal motion, the kinematics of the spine, my hope is that for 5 degeneration, which unfortunately I cannot reverse, but I can slow down. Because our spines all degenerate. There is no magic. I can't turn back time, but I certainly can slow the process.
Walk us through, that process. Like, how is this procedure actually done?
Sure. You sure you want to hear it? No.
Yeah, I do.
So, I use my exposure surgeon that I use almost exclusively is Dr. Wagner, Willis Wagner. If he's watching, he's my man. But and you can use anybody, but we worked together for years, so I trust him, and he's a vascular surgeon. And really a general surgeon or a vascular surgeon can do this, and they do the exposure through the abdomen. There are discs and trials out there that are working on ways to go from behind, but right now the only FDA-approved available artificial disc replacement for the neck or the lumbar spine is through the front. And the reason for that is just the sheer size of the disc, and with placement and anatomy and how they were designed, you cannot move the nerves and the spinal cord out of the way to get a disc in, right? If you move them all out of the way, you lose function. That causes permanent nerve injury. And so when we do a little bit of a discectomy, you can move the nerves very gently, and we're monitoring them in real time, but you move them very gently, take away the disc, and you leave it alone. So you really don't disrupt the anatomy. Here, it's a much bigger implant, and we're taking out the whole disc, so it's actually safer for the spine to go from the front, and that's how the implants were all designed. But to get there, we use a vascular or a general surgeon who goes through the abdomen, which is a very disconcerting idea for a lot of people.
Yeah, I was terrified.
Yeah. So it's really important that whomever you go to, whatever spine surgeon you choose, that you really get a sense that they feel confident, and you should have a consultation with their exposure surgeon. Why do we have an exposure surgeon? I'm trained to go through the brain in multiple ways and the back in multiple ways, side and the back, but really our general surgery training through the front is minimal when it comes to the extent of our training. Very minimal. So it's just, although I know people in Europe have done their own, the standard of care here, and I think it's appropriate, is that you have someone who does this on a daily basis. And so they go through the abdomen, they're splitting the muscles, not cutting the muscles, and they actually don't open the peritoneal sac where the bowels are. So that's a fallacy. People think that they do, and the guts are all, no. The peritoneum is kept intact. It's a covering, like a skin-like covering around the bowels. That remains intact. Dr. Wagner or your exposure surgeon goes in and actually moves those to the side. It does sound a little bit scary, I get it. But there's some give, right? It's not a huge incision, but there's some give, and he has special gentle retractors that go in. And then the most important thing are things like the ureters from the kidneys to the bladder, right? Those are there where urine flows, and then the vessels, right? And so you've got very important arteries and veins that kind of come down and then split right around that area. The reason why L5S1 is considered so boutique and outpatient and safe is that most people, not everyone, but most people's anatomy, the split happens above that. So it's actually the easiest job for the exposure surgeon, because they don't have to manipulate those vessels very much. At other levels, and you know me, I do 3-4 levels routinely, there's more manipulation of those vessels, which is why we have vascular surgeons who do this all the time. I manipulate vessels in the brain, but it's a little bit different. And so they get me to the spine safely, Once his retractors are in, he says it's good. He shows me the exposure. I feel comfortable with what I'm looking at inside. He's kind of done for a little bit. And then I start my work. And my work is basically figuring out a way to get the disc that's diseased out. Now, remember, getting it out is a little bit kind of, prosaic, because you need to do it in such a way where I can get it out without injuring two things. Everyone's like, the nerves. Absolutely, right? And then the vessels are protected by the exposure surgeon, but the nerves, we need to get the disc out away from your nerves. But I also have to be very cognizant of the bony architecture. Unlike a fusion where, if you stick something in there, it's going to fuse. If it's not moving, you stick a piece of titanium, a piece of plastic, put some bone, some cadaveric bone, most of the time it fuses. But for an artificial disc to work properly, I really want symmetry. I want kinematics. I want that flexion, extension, lateral bending, rotation. I want your spine to not know it's artificial. I want it to think it's a disc. So I need the bony architecture above and below the disc to be as native and untouched as possible for you. And so that you have to be careful of. You're careful of the nerves. We're using magnification, loops or a microscope. We make sure it's all out, and we make sure that it's safely removed. There's no remnants. And then the placement of the disc is first actually sized. We're using different implants that are not permanent, that are just sizing you. And I do preliminary sizing on radiographs on the imaging. And we make sure in the operating room that those sizings, those trials with an X-ray looks the way that I want it to look. Because remember, it's a little bit artificial disc, but it's also an artificial scenario. You're lying on your back. There's no way for me to really test weight bearing in that setting. So this only comes with experience and learning how a disc should sit, an artificial disc should sit in your spine, supine, lying down, with anticipation of how it's going to look and perform weight bearing and with activity. Once it goes in, and there's certain techniques that are just kind of little nuanced techniques of how we actually get it into place, secure it, and then we leave, we get an X-ray, see how it looks, and then Dr. Wagner, your exposure surgeon, comes in and does the closure.
Wow. And you make a cut in the bone for the device they used for me, the ProDisc L.
Yeah, which is the only actually available device now, unfortunately, in the United States, but it's also the one with the longest track record in terms of reliable kinematics, motion. You do make a small cut in the bone, which is almost like a fish hook. It goes in one way, but it has a harder time pulling. It's barbed, right? It doesn't go out the other way. So once you put it in there and you do a cut before you place the disc in, and the disc fits in the cut. So everything is done very precisely and prepared before the final implant goes in.
I mean, it feels for me, having one in,
Yeah.
it feels completely natural.
That's the goal.
Yeah. But could there be enhancements to the design of these discs in the future, perhaps, to make them I can't even conceive of how they might feel more natural.
So, if you notice the ProDisc, it has wonderful range of motion and kinematics, but it has very little compressibility. And so what we've learned is that it actually doesn't matter as much. It's actually the motion segment that is more helpful for adjacent segment disease. But compressibility is something we've all looked at. There are viscoelastic discs that are being looked at that are on the market. There was one that was just taken off the market or not being researched anymore in Europe and Australia. It just hasn't panned out yet. But it's an active area of research.
So you're saying the shock absorption capability?
Correct. Not just range of motion but also an additional shock absorption capability.
But I did a little bit of research on the plastic core that's used. It's the same kind of plastic, apparently, according to what I found, that they use. It's like a tried and true material that's used in hips and shoulders and things like that.
Correct.
It's totally biocompatible.
Correct. So that's why it's worked. This particular disc in its various iterations has the longest track record with respect to motion and maintained motion 20 and 30 years out.
What did you see when you saw my disc, from the anterior? What did it look like?
Awful, really ugly looking disc. It's a funny question because people always ask me, how hard is it to do this work? And in someone like you, it actually wasn't that hard to get your disc out because your disc was shot, right? And so if you're having a hard time getting a disc out, I always say, maybe I shouldn't have been here, right? I mean, we shouldn't be doing this if it's a healthy, viable disc. Sometimes we have to do it for other reasons. But in you, the disc kind of explodes out at you, your disc wasn't compressible. Your disc felt like fibrous. It didn't feel like a nice squishy, like the squishmallow things that the kids play with. A disc is collagenous, right? Yours was not. Yours was fibrous, dehydrated, and it kind of just came out very easily. So that my job with you that was challenging was actually getting you opened up safely, to get you expanded safely, to make sure the nerves were decompressed safely, because you didn't really have significant nerve pain, you had disc pain. So the last thing you want to do is create a nerve injury. So that was what was the minutia about your case. But your disc was a firm, fibrous kind of, easy.
It looked bad.
It was bad. The MRI didn't lie.
It was painful AF. I mean, like tilting over a sink to wash my hands, brush my teeth, to put on my socks and shoes. Anytime I would sneeze for the past 10 years, like getting stabbed in the back. I couldn't ride bikes, like bicycles anymore, because of the lumbar flexion And
you asked me about the sneezing and stuff afterwards. You were nervous.
Yeah.
And people ask, what's the resilience of these discs? If you ask, if I sneeze, is it going to migrate into my spinal column?
Is it going to like blow out of my ass?
Right.
I asked you that.
And you did. You asked me a lot of fun. I mean, we can never share our text messages. So the answer is, seeing a migration of one of these discs is exceedingly rare. Like, I'll have people with minor distraction injuries, nerve pain. That's more common than something like a massive migration requiring a revision. The few times I've seen it, it's a kind of a, God forbid, awful scenario, as someone gets into a high-speed rollover car accident. And I always tell people, when they're kind of trying to mitigate risks and they're thinking about risk-benefit ratios, this disc seems to be, over the last 2 to 3 decades, as robust almost as our own native disc, right? If someone has a rollover high-speed car accident, that's when I see you in the emergency room, because your spine is severed. Our natural anatomy, our native discs fail in that scenario. So of course an artificial disc can. But people, you're certainly not going to blow anything out of your ass when you sneeze. I mean, I have people doing ultra marathons, 100-mile runs. I have skiers, football players. We have professional athletes. Is there a sure thing? There's never a sure thing. But the tried, tested, and true truth is that these discs are standing the test of time and active time. Seemingly similar to our native body, but like our native anatomy, things wear. These discs certainly wear, like a hip. They say now, what's a new hip going to give you? 20 years, 30 years? Nothing is forever. The FDA trials looking at, when you do it in vitro in a lab before it ever goes into a human being, looking at there are these really fancy, wonderful looking machines that put the discs in a cadaver kind of spine under multiple iterations of motion, 10 million, rounds of motion. And the idea is it's supposed to last the length of a human life. But we know that the in vitro studies are not the same as the in vivo, milieu. Your body is inflammatory. There's all these processes going on, which is, why you're on supplements, which is why you do things to try to help the anti-inflammatory natural process of the body to any type of surgical insult. It's an insult. It's a trauma going through surgery, even if we're fixing things. And so it will wear like your body, but it will wear slower than a diseased disc and potentially help with the adjacent segment stresses.
What are the factors that make a successful outcome more likely? And does it vary gender to gender, body size? I mean, do small, petite women fare, if the diagnosis warrants an ADR, do they fare just as well as like a strong, muscly dude?
Yeah, great question. So I brought this up because you asked me also about the before and after, but it is a helpful kind of depiction of how I'm going to answer this question. Success is multifaceted. So sure, patient selection, right? People who are heavier, more obese, always have a harder time with surgery, not just because of the motion segments and the device, but just healing. Wound healing in diabetics or in smokers is deplorable. It is exponentially more of a problem, okay? And I bring this up just to show things like symmetry and positioning. It is, my old mentor and I have talked about this at length, and we've never formalized it, but we've thought about trying to create almost like a fellowship, extra training of sorts for arthroplasty and artificial disc, because it is much easier to fuse. And a lot of us who were trained in the original ways of fusing think that we can just kind of migrate into this artificial disc space. And unfortunately, and I think there are a lot of amazing, I'm not the only one, there are amazing, talented people out there, but it's not the same. It's not a fusion. And there are certain things like symmetry, positioning on the sagittal, on the AP, these are different views, trying to look and figure out how this is going to work best for your anatomy. It's not a one-size-fits-all solution. And so the success is really going to someone, well, first of all, taking care of yourself the best you can, which I get is a chicken or the egg thing, because sometimes you're in pain, it's harder to take care of yourself. But taking care of yourself to undergo the stresses of surgery. Surgeons are always skeptical about vitamins and supplementation, but knowing the right combination of things that can help you with healing depending on you. Going to someone who knows the difference between a fusion and artificial disc and the nuances between not every artificial disc is created equal. Not every patient's a candidate. And so in the cervical spine, it's a really important consideration because we have many FDA-approved discs. I mean, there's 7 that I use regularly and other 2 that are on trial. And that's even more complicated because I've actually had this discussion at conferences, giving lectures, talking to the surgeons saying, well, I use this one disc because I've done it the most. And there's some truth to this. If you do something thousands of times, the same disc, you're better at it, you're safer. And I said, I respect that. But I believe we owe it to our patients to, if we're offering this technology, to be proficient in all options. Because it is not a one-size-fits-all solution. So some artificial discs will fit better or function better for some patients. And in you, unfortunately, we only have this one disc available now in the United States, but in you, there is a sizing and a placement issue. So you need to go to someone you feel comfortable with who understands those nuances. That, a safe exposure surgeon, healthy lifestyle, understanding limitations there when someone's in pain, are the best chances of success.
Yeah, I mean, I definitely had been not necessarily in preparation for the surgery, but making sure that I'm at a healthy body composition, going into the surgery, for the 2 months or 3 months that I knew that I was going to do this, I was really focusing on getting as strong as possible. I was prioritizing nutrient-dense foods like red meat, eggs, antioxidant-rich, fruits and vegetables and things like that, and supplementing well. I mean, I was like preloading collagen. I was taking collagen, 20 grams of collagen a day, vitamin C. I was like doing everything that I could to support bone health, the health of my skeletal muscle, so that I could be as strong as possible going into it. Knowing well that I was gonna have to recover from it, and that I was gonna be not able to work out for a month. And yeah, the specific for me, the focus on like the bone stuff. I mean, knowing that you were gonna like cut into the bone, and that the bone at a certain point was gonna need to graft into this.
Yeah, and that's actually an important consideration. If you look at the implant, this is the artificial disc that you have. That high density plastic core, we really don't want to be touched by anything, right? We want that inflammation to remain at bay because we don't want the disc to stiffen over time. So I really do tell patients, even though I don't let you work out in the gym right away, 3-4 weeks, you start getting back to the gym, you start doing light exercises. I want you ranging, I want you moving. It's not a fusion. I don't want it to stay stiff. Everyone says no bending, no twisting, no lifting after surgery. It's not a fusion. I want you to bend, lift, and twist. All right, just lightly. I want you to move because the discs, it's like Newton's law. Things that stay in motion remain in motion.
Yeah.
Right. Things that are at rest stay at rest. And
use it or lose it.
Use it or lose it. And so, but it's a kind of a double-edged sword because I want the disc to move, but I also, like you had just mentioned, I want there to be biointegration of the titanium end plate into the bone because that end plate needs to kind of become one with your bone, and that's important. Which is why, and that is a nutrient poor area, right? There's a very poor vascular supply through that bony area. So it's very important we do get some biointegration. And so you being overall healthy has certainly helped with your progress, which is why I'm left you that challenge. Let's start working out. Let's start doing it, start doing more, because I want you to use it and I don't want you to lose it.
What is what surrounds, like currently in me, what is surrounding this plastic core? Is it like blood or air, or like what the hell is in there?
So you don't have any more free air because the air it really just exists in the gut. We don't want air to be outside of the gut. The only reason there would be air is because we were in there. Right now the air is gone.
Yeah.
So it's not anything other than general peritoneal fluid, abdominal fluid. It's nothing. It's really just a space that is filled with tissue and fluid.
Wild.
Yeah.
One of the biggest concerns, a risk for men going into the surgery, is retrograde ejaculation.
Yeah.
I was terrified.
Sure.
In anticipation of the possibility of that, as small as it may be, I went and I froze sperm.
Sure.
But yeah, maybe talk a little bit about that.
Yeah.
I was very grateful, by the way. The moment I could test, I felt well enough to test my plumbing. I did, and it was fine.
You also texted me about it. Thank you for that information.
Yeah.
So no, but it's a concern. It's for men. There are very small nerves coming off the sympathetic plexus on either side of the spine that are too small to see. You can see the sympathetic chain, and Dr. Wagner, my exposure surgeon, and I are always able to see it, expose it, and keep it safe. But the small little nerves that come from the plexus into the front, usually right around the disc space, are very hard to visualize. And so we always do very blunt, kind of non-sharp dissection away to make sure we're spreading everything carefully. And you just don't know. Luckily, the incidence is 1%. And in the 1% where it happens, 50% resolve. So it's thankfully a very small incidence. But it is a consideration that I always discuss with my young male patients, especially ones that are, childbearing age that still want to have children. It's an important consideration. Another thing to remember is that retrograde ejaculation doesn't mean you can't have children. It just means you have several steps to do. It's not an impossibility. It's just not our standard, more enjoyable way of having children. Becomes a little bit more complicated.
Well, it doesn't change sexual function. It just kind
not
of...
sexual function, yeah. And so it is a consideration I talk to all of my young male patients. And thankfully, I've actually, I don't even remember how many I've done any more of these, but I've only had it happen. It's certainly less than 1% in our case with our group. And I had it happen once. And in that one patient, it resolved.
Wow.
Yeah.
Thank God. Yeah. That didn't happen to me. I mean, I've had no, knock on wood, I had no complications. But it hurt to pee because I guess intra-op, they put in a catheter.
Yeah.
But yeah, I mean, the recovery's been just like, it's crazy.
Yeah, and it's going to be quite telling, to see as you start now. I'm liberalizing your activity, so as you start to do more, I really am excited to see kind of how your level of function, your quality of life, your just overall enjoyment of the activities, changes. And you mentioned superfoods. I think that's really important. Like anybody that thinks surgery is this sort of panacea, even with this type of technology that I promote so strongly and passionately because I'm candid about it, it is still a trauma, right? Surgery is a trauma to the body. And we are fixing one trauma and replacing with another. It's a very high inflammatory stress state. And so things like superfoods, high antioxidant content foods, I can't stress to people listening to your show that you talk about this, you wrote a book about these things.
Yeah.
I mean, this is so important in your daily life, let alone around something like a surgical stress.
Yeah, no, it's super important. Do you think there's value in, for people who are listening to this and possibly even considering getting it done? I mean, one of the things that attracted me to you is that you're a neurosurgeon as opposed to like an orthopedic surgeon. Like in my mind, the care, knowing that you are an expert in nerves to me just stood out as being something that was, I don't know, valuable when you're having such a invasive procedure done. Somebody, who has expertise in the information superhighway of the body.
So, it's a tough one for me to answer, right? Because I have a lot of mentors who are also orthopedic spine masters. In general, I was trained by mostly neurosurgeons as a neurosurgeon, but certainly I've had many orthopedic surgeons, spine surgeon masters who, are some of the best surgeons I've seen out there. I think you need to feel comfortable with the surgeon that you're with and, like you did, speak to their patients, look at the testimonials, do your due diligence. There are certainly very highly trained neurosurgeons that shouldn't be doing this surgery either, right? They focus on vascular problems in the brain. I've clipped aneurysms when I was on call in an emergency situations, but it's not what I enjoy to do. And I'm certainly not an expert at that area, that subspecialty of neurosurgery, like I feel like I am now with this aspect of the spine. And so, and there are certainly orthopedic surgeons that have done extra training and have specialized. So it's really, I appreciate the sentiment. I think that it really just depends on the surgeon.
What should patients look out for when choosing a surgeon?
My motto is a surgeon that is trying to fit the patient to the procedure is the wrong approach, right? There should be this device should be a perfect match. This should make sense. You shouldn't be trying to fit one or the other, right? You shouldn't try to fit the device to the patient unless you're in surgery already, or you shouldn't fit the patient to make it work. Anybody who pushes something on you that isn't a hell yeah, it makes sense, to me makes it nervous. Anybody who pushes a one-size-fits-all model makes me nervous. Anybody who says they haven't had complications makes me nervous, right? And so I think there are a lot of amazing surgeons out there, and there are other people that are learning. I think when people are looking, do your due diligence, speak to patients, look at reviews, but like you said, it's biased because people tend to just, if they're angry, they make a bad review. So it's not always the case. Everyone's going to have a bad review. And, the gut check, my wife always tells me the gut check is one of the most important things that she does in her life. She's a lawyer and young kids, and what's right. I mean, that gut check's really important with a little bit of data, a little bit of due diligence, and, look out for the warnings. No one should be pushing something on you just because they think it's the right. It really should be a marriage. Picture, patient, picture. Things have to make sense. Patient is symptoms, picture is characteristics. The two of them, when they make the most sense, when they talk to each other, when they relate to each other, the highest chance of surgical success. I
feel like people in general, but physicians, I think, tend to be down on what they're not up on. And, some of the opinions that I got, were from doctors that didn't personally perform ADRs. And so their opinion of ADR was very low. Right. Like, I can't tell you how many doctors I saw who were like, ADR is like almost talking about the technology as if it's like a fad.
Yeah. So those are the warning signs, right? I've done fusions. I still do fusions. And I speak badly about fusions when ADR is an acceptable or superior alternative. I don't speak badly about fusions when we have no other choice. It's the right choice. So it is very important to look for people who have perspective on both, but informed perspective on both. But it's the case, surgery, it's a case in life. People always speak badly upon what they don't understand.
100%.
Right. And that's common sense. So I think it's really important. But that's why you and I vibed from the very beginning, and we had a very honest, open dialogue and relationship. And at some point I said to you, look, I'm going to call in the Secret Service to get them to like drag you to but I never really pushed you. I really said, I'm here for you. But at some point, you got to have faith. I'm not trying to do anything to you that I wouldn't do to myself or my family member.
It was definitely time for me. Over the past year, I had been needing to rely more and more on drugs, on meloxicam, which is like a very powerful non-steroidal anti-inflammatory drug. And that might be okay for some people, but for me, I'm well aware of the literature on chronic NSAID use, and
it's not exciting.
It's not fun.
No, not at all.
Increasing risk for cardiovascular events, GI bleeding, and stuff like that. And I just didn't want to have to rely on drugs. So, I knew that the time had come for me to, seek a medical intervention.
Yeah, and remember the caveat to all of this is that you could have a patient that feels exactly like you, but has an image that really doesn't look that bad. I wouldn't then say, okay, we have a surgical answer. The marriage of the two is important. I keep going back to that. It is important to treat you. And so there are many ways to treat you without, potentially getting you involved into, committing to a surgery. We had just used up all our cards. We had no real other option left for you.
Well, I tried exosomes, I tried PRP, I tried all the conservative stuff. And it's like, your analogy, if you ask 100 neurosurgeons, like what the recommendation or whatever the diagnosis is, or the prescription is, you'll get 100 different responses. Well, similarly,
200 different responses. No, they're not all sure.
Well, it's like you ask a chiropractor like what they think, they've got the solution. You ask a personal trainer what they think, and
Sure.
It's like there's a point where you just end up spinning your wheels, and I felt that I was at the point where I needed like a real enduring solution, and becoming more aware of it, in no small part due to you and your sort of advice through this process. Is like, well, the longer you wait, the more you're increasing the risk for these like associated problems.
Yeah, unless it didn't look like this and all of these conservative and holistic management strategies worked, then that's okay. Then we watch. You don't want to go to someone, where feels like a factory.
Yeah.
We're kind of a boutique practice. It's not a factory. We're picking the right patients for the right surgeries. We want the best results. And so, my office, we looked at this data. I think of all the patients that I see, I'm operating on 20% maybe. So it's not like everyone who comes into the office is getting a surgery. If, maybe 10 years ago, this would have looked very different. It may have looked like this. I would have said, you know what? If your 5-1 looked like your L4-5, let's do some PRP. Let's do some injections. Exosomes is an interesting thing. Let's go down that road. Let's avoid it unless we have to.
Yeah, well, nothing worked. What are some questions that people listening to this, like not everybody has access to a Jared Ament. What are some questions that people listening to this might ask to their prospective, physicians? Like, how important is volume? Is it appropriate to ask a physician, like, how many of these are you doing?
Sure, it's very appropriate. I would ask about volume, and I would ask about backup strategies. What would they do if it fails? Not that it fails often, but you want a surgeon that thinks not only about the index level, not only about the surgery. You want to talk and say, well, what's next? How long do you think this will last? No one has a crystal ball, but there's data. Do I need another surgery? And if I do, what's the approach? What could be the option? Ask about volume, ask about risks, complications, ask about their exposure surgeon, how comfortable they are. Do they always use the same one? Do they have a few? Is there a difference? And also, these are nuances that I think are really important that people don't realize. Not all levels are the same. For the reasons I mentioned, not just for the exposure surgery, but you need to know, how's my vascular anatomy look? Where's the bifurcation? Where's the split of the vessels, right? Is your vascular surgeon comfortable doing this inpatient versus outpatient? That some patients may not be comfortable inpatient versus outpatient. I truly believe that if it's safe, patients do better outpatient, not in a hospital setting. But there are some situations where I absolutely will not do it outpatient, and I want to do it inpatient for safety reasons or other reasons. And so I believe you should ask your surgeon about their practice policies and how rigid they are. You want someone that's flexible. You want someone that's dogmatic on one side, but flexible because they can adapt in real time. It's a very careful balance, right? Algorithms are clearly associated with improved results. But if you're so dogmatic that you can't think outside the box, you're never going to get to what we're doing, the artificial facet and artificial disc 360 trial, right? You have to be able to adapt. If a patient has a subtle change in their anatomy, maybe you don't do it outpatient. You go to a hospital and you go to an exposure surgeon that has familiarity with that anatomy or that variant. So you need to ask about the nuances, not just the specifics. Unfortunately, for a lumbar artificial disc, there's no reason to ask about the disc you're using because there's only one now in the United States. There may be a time when there's more. When we're talking about cervical artificial disc, you should ask your surgeon, what disc do you think is appropriate for my anatomy and why? What discs do you use and why? I'm nervous with, and I try to teach, but I'm nervous around this concept of one size fits all, that the surgeon is just using the same disc for everybody. Even in you, by the way, lumbar disc, even though we just have one now, those end plates, the titanium end plates and the keels, there are different shapes, different angles. They have to be measured and matched for you. And we do that in the operating room.
Wow. So cool. Is it appropriate to ask for connections to other patients? Like patients who had undergone?
Absolutely. I think, that's obviously, we ask those patients if they're amenable to those conversations, but I think it is. Absolutely. It's more complicated when you say, can I talk to a patient who had a complication, or because they don't want to talk or they may not be happy. But I think even I always say social media always presents the best of things. I would love having conversations about risks and complications because it's honest. I think integrity and candor around surgical boutique surgical space especially is paramount. And so if you asked me to talk to a patient who still has some kind of strange pain we can't figure out, I would have said yes if the patient was willing. It's those things are okay. The more information you have, but I also caution people on the shopping around to 6, 7, 8, 9 surgeons before, because then at some point, one, you could be causing yourself harm, and I'm not sure any further advice or guidance is helping you. There's a healthy balance. I'm all for second, third opinions. The 14th opinion, which I've been someone's 14th opinion before, I'm not sure at that point.
Yeah. No, it was so great that you connected me. I mean, I was very grateful, and that those conversations helped seal the deal. I mean, your patients love you, and the procedures seem to really work well for them.
I'm glad. I mean, yeah, my goal is I never really, unless people are just doing so well that they forget about me. I mean, I never say goodbye, right? I don't discharge patients from my practice. Patients are like part of the family. Yeah. Always calling, always texting. Hey, how are you? I get pictures just the other day. I wish I could show you. I have a picture. He wasn't able to do it. He sent me a picture. He went to, I don't know what it's called, pro golf, whatever those, kind of arcadey game things, but it's a real golf range type thing with, you can go drinking and have fun. So he went and he hadn't been able to do it. And he showed me one of his friends, and he took a full on golf swing at the range, gave a high five, had some beer. And he was like, thank you. He sent me a video. And I love seeing stuff like that. That's why we do what we do.
Dude, you've changed my life. Like, I literally was at the end of the line. Like, I didn't know what I was going to do. I was like having trouble envisioning my future, like with the degree of pain that I was experiencing. And it's, I'm just mind blown at the success so far,
I mean, again, I'm happy to have helped you. Happy to be of service. Thank you for trusting me.
Yeah.
And to give you the opportunity at this. So I am.
I wish I did it like
absolutely my honor.
5 years ago, 10 years ago. I don't know about 10 years ago. I was managing. But no, even 10 years ago. I distinctly remember like it's about 10 years ago. I was like walking around Brazil, and I just remember vividly being in pain. And, I don't think that my MRI, it was as clear what was going on back then. I think I was diagnosed at the time for just like a disc bulge, but clearly there was something more, nefarious at play. One of the something that I decided to do based on what people were talking about in some of these groups that I joined on social media was an orthopedic analysis of heavy metal sensitivity, which I think is probably pretty important. There's a company called Orthopaedic Analysis, no affiliation, but I signed up. I bought this orthopedic test where you basically send your blood off to a lab, and it tests your immunoreactivity to all of these different metals that are commonly used in implants. Is that something that you would recommend? I mean, for peace of mind, for me, it was very helpful.
Yeah, I mean, for peace of mind, sure. I've actually started to recommend it less and less for exactly your reason, because a lot of people come back with a minor, the lowest level of reactivity possible to nickel.
That's what I had.
I know. Yeah. Which confused you, right? Confused the whole.
Yeah.
And so, because there is a very fractional small, in this titanium alloy, cobalt chrome alloy, there's a little fraction, 0.01% of nickel. And we've never really seen problems with people with a low reactivity. But people who have a high reactivity to things like nickel, we unfortunately actually can't use devices like this, and orthopedic devices. But I tend to recommend it in people who have a known sensitivity, contact dermatitis, when they're wearing jewelry, things that clearly have nickel in your red. Remember I told you, I said put a nickel on you, which I think has 20 or 25% actual nickel in the nickel, and said tape it to your skin for 3 days. Let's see what happens. So it can confuse the picture, but certainly, I mean, if you've had other implants in your body before, then you know you're going to be fine. But anybody who's had any sort of reactivity or is a little atopic, tends to be allergic to things, we certainly do that for people. It became standard for a long time. We did it on all of our patients, and then it really ended up confusing patients more and more, so we stopped.
Well, just imagine if you are one of the rare people that has like high sensitivity to it. And
then I mean, that's certainly worth considering, because we have seen we've seen some autoimmune reactions in that setting. But it is rare. It is very rare for the small fraction of nickel to suddenly leach out of this device, right?
Yeah.
So it's very rare.
Wow. Tell me about Axon Mastermind. I mean, this is something that I've been taking, which is it's a product that you and your partners have developed, and it's got all of these. It's not a proprietary formula. It's very transparent. It's got all of these nutrients that you guys have hand-picked for being particularly supportive of nerve health.
Yeah. So this has kind of been a project that's my partner started a decade or so ago, and then for the last 5 years, 3 of us actually worked on trying to do something very honest and transparent around brain health, supportive brain health, cognition, and nervous system support in and around surgery. I mean, we initially never even thought about making it a product. It was something we just wanted to offer our patients. And I mean, to reiterate a little bit, surgery is a trauma, right? Surgery is a stressor. And stress, what people usually refer to as like the stress hormone response, is cortisol, right? And so cortisol in the HPA axis, right, the hypothalamus pituitary adrenal glands, the adrenal gland produces cortisol, is super interesting because cortisol is actually extremely helpful. In the first week or two, when you got a cortisol surge around a stressor, you actually have improved cognition, improved reaction times, improved short-term memory. But what the data shows, which is important not only for surgery patients like yourself, which is why I put you on it, put all my patients on it, but around just our lifestyle, is that we have very high stress lifestyles that after 1 or 2 weeks of that cortisol surge during stress, you actually see the exact opposite. You see a decline in short-term memory. You see a decline in healing. And so our lives tend to be cortisol laden. Today, we're not sleeping right. We're overworked. Everything around us, the world's on fire. There's a lot of stressors, right? So we looked at this and said, you know what? This is not rocket science, but there is some really good data out there on all of these individual compounds that we looked at. Lion's mane, acetylcholine, phosphatidylserine, coenzyme Q10, DHA, algae-based DHA, vitamin B6, vitamin B12, methylated, magnesium threonate, bacopa. I mean, all of these things we looked at and we're like, you know what? There are ways to really help people heal, and it's like an adaptogenic to help, mitigate the stressor of surgery, but also of life. I mean, my partner and I take this now for the last year before we even made it commercially available. So the concept was, how can we help people with cognition, brain health? Some of the compounds actually have been shown to help with hippocampal changes, short-term memory. Is it proven? Is it, causation? We can't. But the data is very interesting on a lot of these substances. And the idea is help people around the stressor of surgery, but also the stressors of normal day life. Cognition, brain health. We were actually joking. We were saying MBYA, make your brain young again. That's what we're thinking about Axon in this particular kind of our launched product, Mastermind, is make your brain young again. How can we help with healing around a stressor like a surgery, nervous system, and overall cognition, memory, and helping mitigate some of those cortisol effects? The thing about this supplement, again, it's not proprietary, is that we looked at this not from margins. Our margins are so much lower than your average product out there because we spent years sourcing the right ingredients of the utmost quality. You know more about this stuff than me sometimes. I mean, lion's mane. But do you know that the lion's mane that's in our product, you can actually find, and just buy the lion's mane, it's probably the same, if not more expensive on its own. And we've sourced the same. The lion's mane, it has to be extracted the right way, right? There's a concept of like 80 degrees centigrade water extraction. There's a concept of using the fruiting
bodies,
the fruiting bodies, right? Versus the other aspect,
mycelium,
right? The mycelium, where you have beta-glucan rich, which is great for immunity, but has nothing to do with cognition or brain health support. And so we looked, and everything we did was to get the highest quality ingredients into one that we could. Magnesium threonate. Everyone takes magnesium, right? But there's data from MIT that shows that magnesium threonate actually crosses the blood-brain barrier and does more for cellular health, for mitochondrial health in the brain, probably because the magnesium threonate is a little bit smaller, it's a little bit more accessible, but that's not something that's readily available when you go to the store and get magnesium, right? And mitochondrial metabolism health, right, and membrane health, there's exponentially 1,000 times more, if not more, mitochondria in the brain, in the nervous system, than the rest of the body. So we're trying to support that. The vitamin B6 and B12, that's not new, but ours is methylated to help with absorption, right? And so everything that we put in there was to help maximize nervous system healing around stressors, brain health, cognition, in the acute setting and long term. So I'm optimistic that it's something, that it can be something for everyone, especially in this day and age.
Yeah, totally. Well, I mean, first of all, I appreciate the transparency. It's not like a proprietary blend, like you lay out the doses for each ingredient. But I've been taking it. I started taking it 2 weeks prior to my surgery, and I'm still taking it now a month post surgery. And I mean, I'm taking a lot. I'm being incredibly diligent about my diet. I'm prioritizing, as I mentioned, red meat, eggs, things like that. I was also taking some peptides, like I was taking BPC 157 and TB 500. I can't tell you if those have helped because that's just another part of the pie, which also includes, lots of collagen and bone broth and vitamin C and bone supporting nutrients. I mean, I'm taking vitamin K2 and boron and magnesium. I'm getting the magnesium threonate from Mastermind, but I'm also taking, magnesium glycinate and zinc for healing and all this other stuff. I'm like, I really had a pretty rigorous like post-surgery protocol that I've been adhering to. But yeah, I mean, in my mind, just the fact that you're stretching all these nerves, you're distracting and you're going in there, like it made perfect sense to take something that was specifically targeting nerve health.
And that, I mean, I look at this like
lion's mane has been shown to promote nerve growth factor.
Plasticity. I mean, it's actually been shown to actually help with neuroplasticity, which is huge, right? And so that's great. And so I look at this, like you just said, it's not a replace all, right? This is for us a multivitamin for the brain and the nervous system, but this is not a bone supportive supplement. This is not a pregnancy supportive supplement. This is, we think, a supplement that really supports. It's a multivitamin for the brain and the nervous system. So I love that you can't tell anybody that this one particular thing has helped in your healing. And I completely respect that because it can't. It really is the combination and of everything that you've done pre and post-op.
Yeah. I've been using red light.
I saw.
Yeah.
Yeah.
What else have I been doing? Yeah, red light.
Was it hyperbaric?
I did some hyperbaric. Yeah, I did some hyperbaric. But no, I'm serious about recovery. Like making sure that you're recovering well.
And that's why I wasn't sort of nervous about, I've said no to patients. If the relationship with if the physician-patient relationship isn't a healthy one, or it doesn't come from trust, or if it's strained, I've said no. I'm very nervous about that because even if I do the surgery technically perfectly, a patient can have a horrendous recovery. It is a partnership. It's very important that you can feel. So that's another, piece of advice, a pearl for your listeners is feel like you have that relationship with your surgeon. It's very important because surgery can go almost perfectly, not perfectly, and you can still have a great recovery if there's a true partnership in what you do during the rehabilitation process, the communication back and forth. And so just because your surgery happened to go perfectly, I think that you potentially could have done worse or had a longer, more difficult, protracted recovery if you weren't as diligent as you are. So you're making me look good. I appreciate it, but I mean, it's a joke, but I mean that for everyone out there. It is a partnership, and it's very important because you, I believe, will see the results of this be long-lasting. You'll be able to be as active as you want on this disc and have a new spine not only because the surgery is a success, but because you've been so diligent about your pre- and post-operative care.
Well, also, but not all to your credit, like not all doctors are like you. I mean, there's like this lore that you get on average 15 minutes with your physician. I don't know what the, average is for, neurosurgeons who are, prospective surgeons, in this context. But like, yeah, you're very hands-on with your patients. Like that's got to be unique.
I'm me. I want to treat people, it's a golden rule like our moms and dads told us, right? Treat people like you want to be treated. I believe it. I teach my kids that, and I only would ever, treat a patient, prospective surgical or non-surgical patient.
Yeah. Well, again, you've changed my life. I'm so grateful. And, I literally could not have hoped for a better outcome.
I'm so happy for you.
And I hope it lasts. But yeah, I mean, as of today, I'm a month out. Like, I feel like I could do anything. Like I'm waiting for your okay to go back and hit the weights at full force. But yeah, I mean,
I'm giving you the okay. That was the whole point of this conversation.
The okay.
Right? I'm giving you the okay. I have full force, 50%.
Okay.
Half force. But you're definitely, you're at that stage now where I already gave you the okay for some light upper body stuff, right? You're at that, you're at the stage now where I want you to do more. I don't want deadlifts, things like that. But I certainly think that 50% kind of back to the gym, do your thing, start doing more. Absolutely.
Well, 1 month out, I mean, how much can my vertebral bodies be expected to
biointegrate to the titanium, to the metal, the end plates? Yeah. So you already have significant biointegration, but the truth is there is biointegration probably that happens to its maturity 3 to 6 months out. And so I don't let people go back to contact sports or things with high axial load like skiing until about 3 to 6 months out.
So you still want to be careful, like even if like mentally, physically you feel at full capacity.
Yeah, I tell patients because often we're lucky. It's such a great technology, and we are picking the right patients for this surgery. They feel so good that they want to do more. I have a hard time keeping people like you down. I had a doctor that came from the Midwest who was a windsurfer. I don't know and he's like, in 3 weeks post-op, he's like, can I go windsurfing? I said, please don't. I mean, it was crazy. But I always tell patients at the 3-4 week mark, if everything went well and I'm happy and you're feeling well, to start going back to your regular activities, but do half of what you think you can, half of normal. And then we'll go over the next several weeks, especially if you're a contact sport type person, over the next 3 to 6 months to back to professional play.
And then what you and I still have yet to do is there's like the 2-month X-ray, post-op X-ray?
Not 2 months. It's going to be around 6 weeks.
6 weeks.
Now, you are a different case, so there's no science behind this. The reason why I tell patients 4 to 6 weeks afterwards is because patients are sometimes sore. I want dynamic X-rays. We didn't talk really about this during the podcast, but I want it before surgery, not just the MRI, before surgery, I wanted to see X-rays of you moving. Right? Because I need to understand how the spine is moving to see if you're a good candidate for the disc and what type of shape and positioning of the end plates of disc that I want to use for you, because not everyone's spine rotates and moves the same way, right? COR, center of rotation, certain concepts that are important in disc replacement surgery. And so similarly, like pre-op, post-operatively, I want to see, especially before we start doing higher activity, how that disc is now moving weight-bearing in you, how it's working. And most of the time, patients who are a week or 2 weeks after surgery, their abdominal muscles are still sore, they're healing. Their back is sore because of the distraction, because of the pulling the muscles. So if I can't get kind of a full range of motion, the X-ray is kind of useless. So I wait 4 or 5, 6 weeks for people to feel really good. They can do full range of motion on an X-ray so that I can appreciate the kinematics and the dynamics a little bit more. That is absolutely mandatory before any kind of high-level contact sport.
Interesting. Now, what if it's not like you can revise anything, like it's already in there. So would that just guide like PT, what you might tell a PT?
It will guide any kind of postoperative physical therapy, guide level of activity. It's rare that I see a problem. What I could see, your disc isn't moving as much as I like. I need you to do more.
Oh, interesting.
Or your disc is moving perfectly, but I can see that there's a restriction in one direction. I can target therapy to help.
In the first 3 or 4 days post surgery, I remember sitting in my car I was getting some familiar sharp pains in my low back, like sitting in a car seat.
I remember you told me, yeah.
Yeah. And I was a little bit nervous about that. I was already even the first day after surgery. There was no pain where pain would typically show up, like tilting over a sink and putting on my socks, even though I was being very careful. But it was slightly worrying that sitting in a car seat, I was starting to get very familiar but milder sharp pains in my low back and around my hip area, and those have completely gone away. I can sit comfortably in a car for hours.
For different reasons, we talked a little bit about this, you and I, because your disc was so degenerated, your facet was starting to appreciate some of that wear, okay? But now that we distracted, we offloaded the facet, which is great for the wear, but the distraction does a little bit of the pulling up, right? See that separation?
Yeah.
And so it actually is counterintuitive, but you need to weight bear more, push down on the disc, let everything settle, and that distraction pain from the facet feels very similar to hypertrophy arthritic pain. Your body doesn't know the difference, and that's why it's resolved, which I hope reassuring to you when we spoke, because that's a very typical type of pain.
Yeah, and that's also why you you emphasize like actually getting up and walking around like post surgery. Like you're not supposed like this recovery isn't like a passive like just be sitting on the couch like you're not bedridden. Like you're actually like you're behooved to like get up and walk around because the weight bearing on the spine actually facilitates like that biointegration.
Critical part of the rehabilitation.
And conversely with a fusion, like you're told to minimize activity,
So
right?
yeah, I mean, here's the thing. Wolf's Law is one of those things where when you weight bear and you load, it promotes healing. It is the same for a fusion. I want bony integration into the end plate of your disc. With a fusion, you want bony healing across the disc, right? So weight bearing is important. The difference is that with a fusion, when you weight bear, you need to kind of weight bear in place. Right? Any twisting, bending, lifting, that type of thing can cause cracks in the fusion construct that we're trying to create. Whereas for you, I do want weight bearing so that there is biointegration, but I also want motion.
God, fusion sounds so difficult.
It is definitely a more difficult recovery. But like I said, patients have done well with fusions for years. It's not often the problem at the index level. It's what happens to the rest of the spine. And we have to think big picture, especially as people are needing these types of interventions. It seems earlier we want this to be a long-lasting solution, and fusion is not. You're big on social media. On my social media, I always say stop the madness. I mean, this concept of fusing the spine, unless it's absolutely necessary, should be a backup plan. It doesn't make sense.
Yeah, and you can always go in and fuse the ADR
if you have to.
afterwards if you have to.
Yeah, but it's a backup. It should be unless there's instability and a trauma or something really bad. It should always be a backup. It is not a solution to a spinal problem when you're talking about a motion segment.
Well, I'm the biggest fan now of ADR. I mean, again, not to beat a dead horse, but it's thus far changed my life. And thank you to you and all the the time and effort and blood, sweat, and tears that you've put into your expertise and coming on the show and sharing your wisdom with my listeners. I know that there are at least a handful of people out there that are going to be super grateful for it and probably even, feeling compelled to pursue this as a treatment option. I mean, knowing how common back pain is today.
I'm always happy to, even if they can't come to me or they're far away, and just be a sounding board and review things and help give them guidance. But yeah, no, thank you for having me, and it's been fun, and glad we could talk about kind of all these fun little tricks and the idea of stopping the madness, really keeping the spine moving. I really think motion preservation is it's not the future, it's now.
I love it. Well, tell my listeners how they can learn more about you, your practice, and also I know that you've extended a very generous discount to my listeners for Axon Mastermind, this totally awesome supplement that you've developed. So yeah, where can people check that out and connect with you, your practice?
Sure.
More.
Yeah. So I think we're giving everyone 20% off with Genius code is what we're going to use.
Code Genius. Yeah. What's the website?
It's axonmd.com.
Axon, AXONMD.com.
Yeah.
Code Genius.
And then for us, I mean, you can always just look up my name. It comes up probably on Google, but the practice is NSG, Neurosurgery and Spine Group, www.nsg-la.com. And then on Instagram, it's just at Dr. Jared Ament. And I know we've shared a lot of mutual followers. And I always try to do my best to respond. I am only one person, and I know it was a group and a practice, but I don't like, not being personal with my patients. So I do my very best to personally kind of get in touch. And when necessary, my office will kind of take it from there to set up appointments. Out of state, international, we see all the time. So virtual appointments on Zoom, especially since there's a lot of ability these days to do image transfer and stuff, has worked really well for people. And always happy to accommodate in person as well.
Dope, dude.
Pleasure. I'm happy for you, man. I'm really happy that you're seeing the benefits.
Thanks.
I told you so. I told you so.
Yeah. Thanks for dragging me in. Last question that gets asked everyone on the show, Dr. Ament. What does living a genius life mean to you?
Healthy choices. I think understanding that choices are your own, but are also a partnership in the decisions you make. Whatever that means.
Amen. Amen. I like that.
Thanks for having me, Max. It was great.
Of course, brother. Thank you guys for listening. Share this episode around with friends and loved ones. Let's spread the word about artificial disc replacement. I mean, I didn't know about it until I was, down to the wire.
That's crazy.
And
that's crazy to me.
I remember having like a thought a couple of years ago, like, how come, like, because fusion, obviously everybody knows that people are getting fused.
Rods and screws.
Yeah. But yeah, I want to spread the word. I want to help you get the word out about what it is that you do. I think it's super, super important. I mean, again, changed my life. So consider it. Not pushing surgery on anybody, but I mean, damn, back pain sucks. And with that, catch you guys on the next episode. Peace. Hey, if you liked that video, you need to check out this one here, and I'll see you there.